Hi everyone, my name's Upali, and along with Jess, we will be your music co-chairs this year. Welcome to our first event of the year, What I Wish I Knew as a Medical Student. We are so excited to have 6 incredible doctors with us to share their experiences and give you an insight into how they ended up where they are today. We're lucky enough to have 5 of them with us here now, and one is on the way. He's delivering a baby today, so he might be a little bit late. Our music team is really passionate about providing students with surgical skills teaching, networking opportunities and seminars featuring doctors and surgeons who have done some really remarkable things in their fields. As you all know, this year has been a really tough one so far, and first of all, we hope that everyone is safe and well. We have had to make some major changes, and our usual networking events and skills workshops won't be able to happen for the foreseeable future.
Instead, we'll be doing our best to bring you the content over the internet and try to sort of digitalize everything we bring. So if you're interested in participating in surgical skills, if you want access to our online library with anatomy fact sheets, we'd love for you to follow us on Facebook and on Instagram so that you can see all that. We're really excited about what we can achieve with all of you this year. And we're also very fortunate to have our sponsor here with us today. So I'll now pass on to Tamar from MIPS for a brief message.
How should I say hello to everyone in Streamland? This feels, I don't know, sort of weird, because normally I would be at the university talking to a room full of people. Now MIPS, I can't see everyone, I should say anyone, but I'm sure I know a whole bunch of people, and you guys would have known MIPS. We're always supporting music. I think we've been supporting music and their cause for as long as I've been at MIPS, and I've been at MIPS for 4 years, and I know it has been long before that. So I guess at this point I should say welcome to everyone who's on the stream. I guess this is a weird thing because MIPS, we're an indemnity company, and we do pride ourselves in supporting our students. And I guess this is one where we're actually supporting students. When I got contacted by MUSIG about the launch, it was kind of no-brainer to somewhat lend our support to this cause, because we know that MUSIG and what they do, it's very important, especially to the clinical students. I'm not going to be very long because I know that there's a whole bunch of people coming behind me. What I'd love to do is just share my screen for those who are actually on the stream now, because what we normally do is with our members is to just take contact details so we can actually send you your membership to make sure that we have the most up-to-date information, like your phone numbers and all that kind of stuff, which is kind of important now, given that we're not seeing you guys, is to make sure that we have the most up-to-date information. So I'm just going to share my screen now to this QR code. So if you have your phone out, just hold it up to my screen where you can get a landing page, or if you don't have your phone because you're using it now for the stream, just see if you could grab the link that's there. It will take you to a page where you can just put your information in, just your general information, and we'll just send you your membership details just to make sure that it's very up to date. And again, because we're not seeing you guys, it's just making sure that we have that contact. I think there's a 15-second delay with the stream, so I'm going to leave it up for about a few more seconds, so you guys can grab your phone out and just use your QR code. Again, if your QR code is not on, if you don't have a QR code, you can just grab that link that's right there, and you can put it in your browser. It's just very important at this time because we're not seeing you to have your details and to make sure that your membership is up to date and we have the most up-to-date information for you. I was told that there would be a few first years, and normally would see the first years I think at the big day, which is the O week, but unfortunately because of COVID-19 we didn't have O week, so we missed you guys. So in a few seconds I'll play a little video just to give you a little bit background about MIPS. It's kind of hard to tell you all that we do and how we support you guys just from this particular forum, because I'm always at Monash, and I get to see the students and talk to them and answer their questions as it relates to indemnity insurance, which is what MIPS does for the first years who probably don't have any idea about indemnity and MIPS. But we look after students and provide them with indemnity insurance to make sure that they're covered for both preclinical and clinical years and that sort of a thing. So I'm just going to just play this quick video just so that you could get a better understanding, at least some understanding of what we do. Doesn't look like it's going to play today. Okay, so I'll stop share the screen. Now, I know there's a few final year students that are probably on the stream as well. I think Anshula, your final year, and I believe that there are a few more. I know that you guys are going out to hospitals probably next month, if I have that information correctly.
It's all been online for us right now in terms of pre-internship seminars and things.
Okay.
Yeah.
Okay. But at this point in time, if there's, as it relates to indemnity and just cover, just any questions that you have, because I know it's a very different time, you know, as Dr. Staunton Smith said, this is going to be the new normal, and nothing is normal about how we're operating right now. So, you know, indemnity and all that kind of stuff will look a little bit different. So if you're clinical students who are out who should be out in the hospital and you're not, or you're doing stuff online and you want to kind of get a sense of, you know, how your indemnity works and how you be covered, feel free to just contact MIPS if you're a MIPS member, or if you're not a MIPS member, just make sure you contact your own indemnity company. I think the message that I want to give tonight really is that MIPS is still here to support you, even though it looks crazy. Different times we're all in lockdown and that sort of thing. We're still supporting our student population, and we're definitely here to hold your hand, and we're not going anywhere. All right, so just if you have any issues, any questions, the MIPS members, you know what to do. Just go online and look us up. I think I have a question here or a hand up from Danny. Is that a question from you, Danny?
Just giving you a clap, Tamar.
Oh, thank you very much. I'm not sure if there's any questions from the general stream. And I think, Anusha, if there's no questions, I will definitely hand it back over to the Capable Music team.
Hello to everyone, our speakers and everyone listening on our Facebook Live. So our event tonight is basically in two parts. So the first part will be meeting all our speakers and getting to understand what they do and what their life entails. And the second part will be our Q&A session. So I'll start off by introducing all our wonderful speakers one at a time. And if you could all just provide a few minutes to introduce yourselves and talk about your journey to where you are today. So I'll start off by welcoming Professor Michelle Leech, who wears multiple hats as the Deputy Dean of Medicine at Monash and is also a consultant rheumatologist and also involved in research in inflammatory diseases. So Prof Leech, handing it over to you.
Thank you. I don't know how that happened. Thank you so much, Angela, and everyone in music and Tamar for inviting me this evening. I love coming along and especially like to hear the other speakers, actually. So I'll be quite quick. Yes, as Angela said, I'm a rheumatologist, and I think a bit later on we get to talk about how we chose our specialty. Is that right? But we don't do it now. But I have, I can do it now. Yeah. Okay. Well, very quickly, I'll say the main reason why I ended up choosing rheumatology was largely to do with the colleagues that I work with, and also the kinds of patients and the kind of work that we do. So for me, I really enjoyed, when I was a young medical student, I was on a rheumatology ward round, and there was a group of consultants back then. In those days, that was back in the last century, of course. There were, when I graduated from Monash, there was actually quite a lot of male consultants, but there weren't very many female consultants back then. There were quite a lot of female registrars. And on the rheumatology unit, though, there was one female consultant, and she, there was a particular moment on the ward round, which I can remember, where there was a really complicated, difficult patient with, you guessed it, lupus, and everyone was talking about this case and, you know, this patient and how, what was going on, and it was really complicated. And there was just this one moment where I just looked up and I saw that there was a group of male consultants, and they were all looking at this female consultant and waiting for her to, give her wisdom on this issue. And I just was just blown away, and I thought, wow, I want to be like that. And she was just had this fantastic poise, and she was so impressive in the way she thought, and she clearly had the respect of her colleagues, and it just was an amazing example. But also in general, the rheumatology colleagues that I've met, I'm famous for saying that rheumatologists on Netscape, there was that big survey in America of Netscape internal medicine folks, and the happiest were rheumatologists in that group of all the disciplines. And that was sort of, even though they were more likely to drive a Toyota Corolla, but they were still somehow happier. And I think one of the reasons I feel it could be is that the mysteries just persist, So the mysteries just keep going. Like you can never, ancora imparo, like I'm still learning, 3 decades on, things are being redefined. The mysteries keep going. I have to use my brain on every ward round. My brain gets taxed. I don't walk in and think, aha, it's obvious what that is. Like I get to come in and do the house gig, and think through, it could be something really complicated. And so it's not algorithmic, and it's not always pattern recognition. So there's an art and a science to it. The next thing I love about rheumatology is the fact that you get to be with your patients for a long time over the long haul. Like I think Tim would, and perhaps some of the other people here would too, but I'm pretty sure that Tim would know patients over a long period of time. I've known some patients now for 25 years. I know their grandchildren. I know their children. I know what their children are doing. I know them. And I love that about what I do. I get to know them, and I get to watch them through life. And I also get to learn about how their disease or their malady affects them across their lives and affects their whole family, and also how their attitude to it changes in the different decades of life. So you just learn. I keep learning a lot. And so, mainly the colleagues are good, cool people. They're easy to be with. There tends to be not too much status anxiety in rheumatology. There tends to be a sort of more of a chilled out. I don't think there is. I think ID physicians are the most socially responsible humans I've ever met, and probably GPs and public health physicians. They're very socially responsible people. ID physicians are very civic-minded. Rheumatologists are not as civic-minded, I think, but they're just good people. I like being with them. So I love the colleagues, I love the patients, and I love the mystery. So that's my summary. Bit long.
Thank you for that. That was really insightful. Okay, so on to our next speaker. So I'd like to welcome Mr. Ross Triolo, who's an ENT surgeon with interest in pediatric ENT, nose and endoscopic sinus surgery, and transoral robotic surgery. So over to you, Ross.
Yeah, hi guys. I've been back from my fellowship for 1.5 years, and I've got a practice which is based 1 day a week in a public hospital and then 4 days a week in a private hospital. I've tried to keep my private practice in one location because it made everything a lot easier. And also it's meant I could make a bigger commitment to my work in the private practice as well, which is something unusual for ENTs because a lot of us work over multiple locations. I've got a wife and I've got 2 kids. I had my first child when I think it was 6 months prior to getting onto the ENT program. So I was still an unaccredited registrar. And I just had my second child only earlier this year. It was certainly a challenge having children during registrar training. And it was sort of, even though we were thinking about having children while we were away on our fellowship, that was also actually quite hard in the end. So we waited until we got back. I get a lot of satisfaction from my general private practice now, probably more so than I thought I would when you're a registrar and you're in the sort of academic tertiary centre. But you feel like what's the way to say this? it's harder to, I think you really feel responsible for things when you're the one seeing them right from the beginning through to the end, and you know whether you've done a good job or not. There's no hiding from that. So that's, I find very rewarding when people are happy at the end. We've done something a little bit different in my practice where I have an ENT nurse practitioner. She is, so she's able to function almost like an intern in some ways in a private hospital. But I found it quite nice to have someone else that I can bounce ideas off, because sometimes it can be quite isolating when you're in private practice as a surgeon, I find. I'm working on my own, so I'm not in a big group. And I like that because I've got, quite fixed ideas about how I want to do things. But it is certainly a big change when you go from having chats with everybody all day. So I can say one of the things I love most about my one day working in the public hospital is that I get to mix with everybody again. I get to have a chat with the registrars and the fellows and the residents and all that sort of thing. So I hope that sort of sums up where I'm at in my practice at the moment.
Well, that's great. Thank you. And then next, I'd like to welcome Dr. Tim Staunton Smith, who's a GP with an interest in LGBTQ plus healthcare, sexual health and mental health. So Tim, on to you now.
Thank you. Yeah, g'day everyone. I guess I'll keep it nice and short too. So currently I work part-time as a GP in a practice in the CBD, so called CBD doctors. Which is funny when I'm ringing up people saying, hi, it's Tim Staunton Smith from CBD Doctors in the CBD. Doesn't really roll off the tongue. So I do that a couple of days a week, and then I'm a 0.6 senior lecturer with the Department of General Practice at Monash. And so I do a bit of academic project work and then a bit of clinical work as well. And I'm old, so I can't really go through my whole how I got to where I am, but certainly at the beginning, my choice to do general practice was informed partly by my dad was he was a rural remote GP when he first started work, and then he became a rheumatologist. Was his career, most of his career was a rheumatologist, so I sort of had an idea about the medical world. I'm a Queenslander, so I did my intern year at the Gold Coast Hospital, but I found I just didn't like being in a hospital. I really was very, very keen to get out and be independent and be working. And so general practice for me was the quickest ticket out, I suppose I would say. And then I've worked in all sorts of different general practices through my life. It's been fantastic for me because it's given me a lot of variety, and I've worked overseas and worked all over Australia. And then the last 10 years or so, I've been doing other work besides the clinical work. So I've sort of started doing some other project work, whether it's with PHN or Medicare Local or with universities. So I've sort of varied, opened up to other things now. But yeah, so, and I'm assuming there'll be other questions that come in that I can answer specifically. So, but yeah, now I work part-time as GP and 0.6 as a senior lecturer. Most of my clinical work the last 10 years has been in university health services. So up until the beginning of this year, I was working in uni health services for the last 10 years because I've particularly liked working with young people in the clinical world. And thanks very much for inviting me along to chat and answer questions. It's nice to be part of the crew.
Thanks for being here. And next, I'd like to welcome Dr. Neela. I'm going to say her last name wrong, but I'm going to try. Janakiramanan, who is a plastics and reconstructive surgeon with a particular interest in complex hand, wrist, and upper limb conditions. So on to you, Neela.
Thanks, Angela. So my journey, when you look back on it, it seems roundabout, but it was actually pretty straightforward. I didn't really foresee a surgical path. I wanted to be a paediatrician when I was a medical student. And then a variety of very complex reasons meant that my paediatric elective as a final year student in Ethiopia fell through at the last minute. And I found myself at a surgical hospital in Cambodia. And it was a hospital it was an NGO hospital, did a lot of reconstructive orthopedics. And my first patient that I operated on when I arrived there was a 16-year-old girl who had fallen from a height when she was about 2 or 3 and sustained a malunion of her tibia and fibula in one of her legs and hadn't walked since that time. One leg was significantly shorter than the other. So in my first day there, we did a corrective osteotomy. And in my last day there, which was 6 weeks later, she stood up and she walked. And for me, that was a really powerful experience. I thought, gosh, I want to be able to do that. And so that's when I decided to pursue a surgical pathway. And for me, it involved learning everything that I could about what it took to get onto the training program, and then spending some years just ticking boxes for research, ticking boxes for volunteering. Fortunately, it was all stuff that I was mostly interested in. I did a master's of public health along the way as well. And again, my career goal was to be an orthopedic surgeon. And my journey into plastics was very accidental. I sat down one day as a resident and I thought, right, okay, in orthopedics, what do I want to do? And I realized I didn't really love hips or knees or ankles or feet or backs or shoulders. But I really liked hand surgery. And in Victoria, a majority of hand surgery is done by general plastic surgeons. So I started spending a bit of time with a plastic surgeon who offered me an unaccredited job, and I said sure, because I was sick of doing nights, because I didn't appreciate how many nights surgical registrars actually did. And then during that year, they said, oh, why don't you apply for the training program? And it was when you didn't have to pay $2,000 to apply. And so I applied and they put me on the training program, and I thought, oh, okay, great, I'll be a plastic surgeon then. And I think we'll talk a little bit about things that have surprised you about your specialty. But what I would say is that there are parts of my specialty that I love. I love the hand surgery part. I then finished my training there, did a couple of extra years of fellowships in complex hand and wrist surgery with orthopedic surgeons to sort of cover that bone side of things. But there's stuff in my specialty I really don't enjoy and which I really don't do very much of anymore. So I think what I would say is that even though we've all, and I don't want to speak for everyone, but I think a lot of people do have slightly meandering journeys to get where they want, but you never lose the opportunity to pick and choose the bits that you like and to upscale the bits that you enjoy and downscale the bits that you don't. And even though it looks like a lot of people lead very rigid careers, I think some people probably do lead very rigid careers. They come out, they pick up whatever portion of public-private they want, and they just do that for the next 30 years. I think a lot of people do find a more meandering path. For me, it's about 2 days a week public, 3 days a week private. To be honest, I would probably do more public if those hours existed. But it's a bit tricky in surgery because you only get extra hours if there's an empty operating theatre. So there's actually fundamental infrastructure issues to the number of surgeons you can hire at a public institution. I found other ways to amuse myself, I suppose, because you do get to a point where your day-to-day practice becomes very comfortable, even though some of the stuff that I do is pretty specialised and there's not a lot of people in town who would do it. 90% of what I do, I no longer break a sweat about, which is nice. But it also means that, as someone who has been through school and through university and through surgical training and through fellowships, where you are being intellectually stimulated and pushed all the way through to finally get to a point where you're comfortable, you could end up a bit bored. And I think that this is part of what all of these discussions are about, is to hear from all of these diverse people and find out how they stay interested 10, 20, 30 years into their post-medical school careers. So I do a bit of writing and I do a few other things.
Thank you for that. And finally, I'd like to welcome Professor Danny Liew, who's a consultant physician at the Alfred in clinical pharmacology and general medicine. And he's also extensively involved in clinical outcomes research and cardiovascular outcomes research. So, Danny, if you'd like to introduce yourself.
Thanks, Angela. I was having a lolly there. I was trying to time it so that I would have it and finish it before I have to talk. I think I timed it well. Firstly, thank you for the invitation to speak. I'm humbled by my co-panelists, to be honest. Secondly, I wish all of you are well, all of you students. It's a tough time, and I know that COVID disrupts lives, and including your training. But you're in very good hands with Michelle and her teams. My journey isn't perhaps that interesting. As you said, Angela, I'm predominantly an academic. I work at the university at the School of Public Health full-time, but I do have the equivalent thereabouts of 3 sessions at the Alfred in general medicine and clinical pharmacology. So those are my dual trainings. I chose clinical pharmacology first, actually, because like Michelle, I was motivated and inspired by the right people. I was very lucky to have 2 mentors who were also clinical pharmacologists, and they were also very academic, and it seemed to be a subspecialty that lent itself well to research in particular. I did general medicine because I like variety, and general medicine is a variable across different states and cities. In Melbourne, fortunately, we are in public hospitals at least have a very strong gen med presence, which most of you know would be the managing people with comorbidities, often complex. Reiterate again what Michelle said. I've been struck by how much this craft is an art more than a science, and especially for someone like me who's not an interventionist, like Ross and Tim and Neela and maybe even Michelle, who injects. I forgot which end of a needle is the pointy end almost. To that end, then it's about knowledge and how you use it and how you apply it to improve people's lives as much as you can, especially people who are very vulnerable. That's what gets me out of bed from a clinical perspective, and that kind of my career that balances academia is a really nice one. I enjoy that sort of balance. I couldn't do one or the other full time, to be honest, I think. And I came to a stage recently, very recently, where I was thinking maybe I should start to wind down on clinical work. And then COVID came along, and I was rostered on wards, just finished, and was bracing myself because everyone was anticipating that would be the peak of it or coming to the peak of it. And Gen Med, we look after COVID patients. And I finished 2 weeks and said, I'm not going to give up clinical work for the rest of my career, because I could talk to I'm blue in the face about COVID and how to prevent it and how to measure its outcomes, etc. But it's all pretty irrelevant if you don't lay hands on people.
Yeah, that's great. Thank you, Danny. And our final speaker is Dr. Shavi Fernando, who's unfortunately not here tonight, as he's an obstetrician and gynecologist, but been called in for a birth, but he sends his apologies.
He actually just said he'll join in 10 minutes, so we might get a little intro from him soon.
Amazing.
Yeah.
Should we start with the questions in the meantime? Then yeah, all right. Okay, so thank you to all our speakers for introducing yourselves. And so yeah, I'll just start with a few questions, and if one of you could just nominate yourself and answer it. So the first question is, what is something about your specialty that surprised you or didn't match your expectations?
If you like.
Yeah, sure.
Sorry, it's a residual bit of jelly. I beg your pardon. I was struck when I became a consultant about that it was more compassion that made a physician, an internist successful, or clinician maybe, than what he or she knew. And especially in this day and age, knowledge is fairly easy to acquire. Obviously, we need to put that knowledge into perspective and our experience, etc. but really it's how we use that knowledge and how we communicate that to our patients, make sure they understand it and give them the capacity to make informed decisions, which are very, very difficult decisions for the most part. As a med student, I used to think and be in awe of all the knowledge that all the consultants had, but what I was really should have been in awe about is how they use that knowledge.
Thank you. And the next one is, what are your tips for someone who doesn't know what they want to specialize in?
I should do that one. Can I do that one? Person, I mean, I wanted to be everything, a GP, an oncologist, everything. I still do, actually. And when I love these events because I think, oh, I want to be all these people. And I think all of the medical students that I meet, I just cannot get over how total potential they are. You know, they don't know it, but they are. And it's just what Neela said before, you know, you might go into this, you might go into ENT, but, you know, you might specialize in something, like you might help, you know, you might have a public health or social facing aspect of your ENT practice, or you might, you know, so people kind of feel as if the path is clear, but it isn't. The meandering keeps going. So you think that you are somewhere. Tim would be the best example of this. My goodness, he's just done everything I can think of, really. But yeah, so I think that my advice would be you are a total potential stem cell and don't ever forget it. And there's everything that you can do. I just want to applaud what Danny said because I really agree with that. The number of patients that have come to me and given me just the most unbelievable gifts and thanks and, you know, lavished gifts and flowers on me, right? And I think, what the hell have I done? Like, I haven't even changed their medication. I haven't, do you know, like there's patients where I actually think I might have saved their lives. Not many, but there might be a few. And, you know, those people, you get zip. Like, you know, you apply your incredible incisive knowledge that you've learned through medical school and you apply that and you think, goodness me, you know, I think I might have saved that person. But the people that thank you are just the people who they feel that you are using your knowledge to help them, that you are democratizing that knowledge, that you are their advocate and that you are on their side, and that is the thing that makes the difference, I think, between a good clinician and a great clinician. So anyway, yeah, but you're all total potential stem cells. That's my advice. Sorry, over to other really more total potential humans to respond to that.
I was going to say don't stress about it because certainly I see that a lot in my dealings with some of my medical students that I see. They get very stressed that they have to make a choice and they need to know where they're going. And sometimes it does go on a linear path, but the meandering for me has been the best thing about my career, I think. And that, doing lots of different things, but trying to do them well, and exploring lots of different things in life has been what I've really enjoyed. But certainly if you're early on that career path, my advice would be don't stress about it. And then the other thing is that you can pick one, you can always change as well. And I think that's one of the things for you guys to be thinking about is you probably will be have working life well into your 70s. And there'll be lots of opportunity for you to meander in a different direction, whether it would be, as Neela said, upscale some things in your career and downscale other things. There'll be lots of different opportunities, but try not to stress about making that first step because the others will become obvious as you move forwards. The end.
The one thing I would say that I was I've been reflecting on a lot in the last couple of years is, and I don't know if it's a system problem or it was just a problem with me, but I found it really hard to get a sense of what different specialties did when I was a medical student and a junior doctor. And I think it probably is a little bit of both. You know, today I operated with a resident, and, you know, he'd been on our term for months and no one had really shown him how to suture. So it's I think we do forget the younger people who are running around and trying to work out what we do. And I think evenings like this are fantastic. I don't think that we had as many when I was coming through, or I don't know, maybe I was at the pub. I'm just trying to remember. But, you know, in the last couple of years, one of the great things that I did was some pro bono work, helping with the Medivac legislation. And as part of that, my role was getting a whole lot of specialists in a lot of different areas to assess patients with complex problems. And for me, it was a real insight into what all of these people, from, you know, GPs to rheumatologists to neurosurgeons, actually do day to day, and the expertise that they hold. And for me, it was a year of just going, oh, I want to do that, and I want to do that. Oh, I want to do that. Oh, shit, I finished my training, but I still want to do all of these things. And so I think what I would do is be a bit nosy with the people that you get to work with and try and work out what it is that they really love about what they do. Don't assume that what you see in a public hospital or the one GP clinic that you get sent to is necessarily representative of what they do day to day, or necessarily even the bit that they enjoy of their job. You know, try and work out what the cool stuff is that they do, because a lot of specialties do a lot of cool stuff that you just don't see.
Thanks everyone for that input. I think we've just lost Angela briefly, but I've noticed we have a new member that's joined us halfway through that. Dr. Fernando, welcome. Would you like to introduce yourself?
Sorry I'm late. I was just, everything went well, just so you know. A very small baby though, 2.5 kilo baby. I'm Shavi Fernando. I'm the Director of Curriculum Assessment for Women's Health, so the CAL for Women's Health. I sort of went through a pretty quick pathway through the Women's Health training. So I did my undergrad at Monash, took a year to do a BMed Sci. I actually started in the first year of the 5-year course, and then took a year to do a BMed Sci, published that, presented that as a student, and then did my internship at, back then was Southern Health, and then started the ONG training program as a PGY2. So I was a level 1 PGY2. The most ONG I had done, clinical ONG I had done by that point was what I had done as a medical student. And then, so I did the training program at based at Monash, did my senior registrar year at Dandenong and 6-month block in Mildura. And then I started my PhD at the end of my training, finished that about 2 years ago. And now I do a mixture of public, private research, students, looking after the students for women's health. And I've got a young family as well, 2 young kids, a 4-year-old and an 18-month-old, who I try to see as much as I can, but on evenings like this, I often don't. But I try to catch up where I can.
Shavi, you forgot to mention the most important thing in your career.
Oh yes, Michelle taught me.
No, not that.
She was my clinical bedside tutor in third year.
No, goodness me, not that, Shavi, for goodness sake. What I want to say is the best career move was you married a rheumatologist.
That's right. So my wife was a rheumatologist. It definitely was a good career move. Yep. I tell my students that if they want to do ONG, they probably need to marry somebody who is either not medical and preferably a teacher or in the arts, or somebody who's medical but has a very predictable 9 to 5, no after hours, no on call kind of roster. The rheumatologist fits that gap, so it fits that perfectly.
Just actually to draw you out on that, I'm not the moderator, Shavi, but can I ask you, I mean, is it possible to do ONG in a way that is less hectic in terms of share parenting? And, you know, a lot of people watching are going to wonder this. You know, you've chosen to do it in this, you've done your PhD, you've charged through pretty fast, you know, your training, and you've got it done. But, you know, there would be options, wouldn't there, to get through this if you were co-parenting? And
yeah, definitely.
I guess it's important for the people listening.
Yeah, definitely. I think you can make it as balanced as you want it to be. It just means that you can't dictate your hours. So somebody tells you what to do, but that's the same in any training program. But compared to the surgical trainees, the ONG trainees have it pretty easy, I think. You're locked into a EBA 45-hour week, more or less. The stress levels are quite high and the stakes are quite high as a trainee. Once you're a consultant, you can largely dictate how busy you are. And the main issue when you're a consultant is in private obstetrics in terms of hours. But it's not really like I hear students and people who don't really know the profession very well say quite often, you know, doesn't it bother you having to get up at 2 a.m. on a regular basis to deliver a baby? And the way that I think of it is that because I love what I do so much, that actually getting up at 2 a.m. is better than a patient delivering at 2 p.m. when I'm actually supposed to be doing a Caesar list or being in a public clinic or being in a private clinic where I have to then reschedule all my patients. So it interrupts the day, which interrupts myself, but also the rest, all my patients as well. Whereas in the nighttime, it only interrupts my sleep, which if it's doing something that I love so much, that doesn't bother me. The real difficulty in obstetrics, private obstetrics, is the unpredictability. And at 5:30, my patient was fully dilated and ready to push, so I had to go in to do that. So that's really the challenge in obstetrics, is the unpredictability. But there is as a consultant, you can choose to be less busy and still earn enough money to pay the bills. So you can do and it's really private obstetrics where the problem is. If you do gynae, you can do a 9-to-5 operating job basically, and it's pretty standard surgical thing. Apart from complications, there aren't really that many emergencies. But if you do private obstetrics, you can limit it to say five births a month, and you can cap your numbers if you want to. You can limit it to 5 births a month, and that means really theoretically you could only be interrupted 5 times in the middle of the night in a month, and that can work quite well with work-life balance. I think it all depends. On how on what you want to do, and you do have a reasonable amount of control. There are now also group practices, which a lot of people, like a lot of obstetricians, subscribe to, which basically they have a rotating roster, so they each have a weekend off, and their colleagues cover them. One of their colleagues cover them for that weekend. The problem, or the thing with that is, like, for example, I'm in a group practice, but we don't use that model. And part of the reason for that is that when you have a patient who chooses you to look after them, they pay you to look after them and deliver their baby, then you want to do that. Like, it's not that you know the patient really well all the way through her pregnancy, and then to miss out on the birth just feels like a real, like you feel like you've lost something. Like it's a selfish thing more than anything else. In fact, that's the hardest thing, is to pull yourself back a little bit sometimes and say, actually, I need to have a break. I need somebody to cover me for this weekend so I can go to the beach or go for a small trip or something like that. And that's the hard thing, at least for me, that's the hard thing I find. So if I go on leave for 2 weeks, I feel guilty telling my patients that I'm going on a holiday for 2 weeks. It makes me feel guilty because I actually want to be there. And when I'm on my trip, I'll check back, like I'll check my my medical software and check whether they've delivered yet, and check whether I've missed them or how many I've missed on the while I'm out. And it's not because I want the money from their birth, or it's not because of any other reason except that I know the patient really well and I really want to be there for their birth. But you have to kind of let that go sometimes. And sometimes it takes your spouse to remind you that you have to let that go. Because obstetrics is addictive. And it's, and I imagine it's like a lot of other specialties too, but particularly if you love it, when you deliver a baby, you get a real buzz. And I've said to a few students already that when you're an obstetrician, you don't need cocaine, you just deliver a baby. And it's basically the same thing. I've never tried cocaine, but I'm told you just a real it's a rush. It's a real rush, and it's a really nice feeling. It's a great feeling, and you just feel like you want to go out and get some more. And
the next question that's coming through is, if you could go back to when you were a medical student, what would you do differently?
That I should have worked harder as a medical student. When you're in the depths of being competitive and trying to get where you want to go, and all of these sort of very rigid career goals. Whereas now I look back upon my medical student days as some of the best days of my life. We lived in a share house. We were poor. Everything leaked. The cold air just flooded in, but our house was full of friends, and it was a really, really nice time. And I fully appreciate that the medical student experience nowadays is perhaps not what it was for us when rent was affordable and youth allowance was, wasn't as much of a shortfall as it is now. So again, I appreciate I'm speaking from a massive place of privilege. But what I would say is that I think in medical school, and I'll say this quietly so Michelle isn't listening, but have fun, and learn what you need to, but also trust that we're all still learning. I'm absolutely still learning, and so I couldn't have learned everything that I know now as a medical student. And so just accept that when you become an intern, there will be holes in your knowledge, and even as a consultant there will be holes in your knowledge, and that's why we're a medical community and we help each other. And I still call up my mentors and say, what did I do wrong here? Why didn't this work? And they say, oh no, you didn't do anything wrong, or oh, it's just some people have weird anatomy. But I'm being slightly facetious, but I reckon have fun and find out who you are and find out what you want from life, and that will help you choose what specialty you want to work in. Because everything Shavi said was great. If you love it, you don't mind that you're there for 24 hours a day. But likewise, I don't think you have to love the specialty that you choose that much, and it's totally okay to go, actually what I love is windsurfing. And I want to pick a specialty that lets me work 9 to 5 and windsurf, because that's the thing that I love. One of the most humbling experiences truly of my life was I was having this conversation with a resident, and I said, we can all choose a career that we love, or we can choose a life that we love, and the career pays your bills. And I was being very simplistic in the way I was framing it, and a theatre tech piped up from a corner of the operating theatre. This was at 10 o'clock at night, and he said, or you could like one of us, and you just work whatever job you can manage to get to pay the bills and pay your mortgage and put your kids through school. Which, was a real sort of heart-stopping, embarrassing moment for me, that we do have the privilege to be having this conversation at all. So appreciate that privilege and do something good with it.
Love, but I wish when I was a medical student I hadn't been so obsessed with or worried about the fact that I thought everybody else knew more than I did. I wish that I had realised that knowledge is just, like as Danny said, you can just go out and Google it. It's just not a big deal anymore. It's just how you apply it. It's character is destiny. It's who you are as a person. And, it's not about who knows more than someone else. But, medical schools are not very good like that. I'm trying desperately to make our medical school not like that. But, there are some powers that be that believe in excellence, you know, in everything. And it's really hard. I mean, every time I try to make things chill, you know, somebody will jump up and say, it's not rigorous. And I think I disagree with that. I think you can have rigor and you can have expectations, and you can have competencies, and you don't need to have this stepping over other people's dead bodies to be, you know, top of the class. I think we have to change that philosophy of medicine and have fun, be healthy, be good doctors, and that way we'll be better for our patients. You know, patients definitely have never asked. You know, the last clinic, that's what I always say to the year ones, the last clinic I was in, no single one of my patients asked me where I ranked in the medical school. Much to my disappointment, they never said, where did you rank? You know, what mark did you get? Would you get a high distinction, Professor Leech? You know, it turns out they don't care. You know, they actually don't care. And they're the people we're here for. So let's just change the way we think. But it's very hard because training programs do not promote this, can I say? So I can work my butt off in medical school to say, let's not get obsessed about grades. Let's just take the grades away, right? And the students will freak out because they need to show their transcripts for the training program. So I would reflect it back to, you know, people in the training programs to say, let's try and find a different way, because if we can, I think we can take a lot of this agony away from our students. But there's no point me saying, look, I'm not going to grade them when, you know, every training program and the PMCV needs a rank. Okay, so if those training programs start to say, hey, we're going to ballot it, we're going to do whatever we do, I don't know, because as far as I'm concerned, all of these graduates are good enough to do whatever they want. Mostly, you know, very small number who have got various whatever issues, but it's a tiny number, you know, who maybe need a break or medicine's not right for them. You know, it's just a small number, but the rest of them are just so capable. They could do anything they want. And why do we put them through this hell? So that's just my perspective. So I just want to add that, Neela, because you can say what you like. I love your idea of having fun. All right, let's carry on.
Angela, I just wanted to say, so just, I mean, I was pretty, I had a fairly carefree medical school, and probably the best thing for me was the lifelong friends that I've made from my experience at medical school, and that was the best thing about medical school. But thinking about things, if I had my time to do something differently, without sounding a bit too serious, I did want to say that there was times at uni when I struggled with some mental health, some depression, and I didn't ask for help. I think now, I mean, it's easier to say now because I'm better at asking for help, but thinking about if I would have done things slightly differently, and maybe if there's someone out there who will hear this, and that is, I wish I'd had the courage to ask for help when I was at uni, because that would have been helpful in a few different ways in my life. But otherwise, my uni life was pretty good. Yep.
Thank you for that. And the next question is, what are the biggest challenges in transitioning from a medical student to an intern?
I'll have a go at this one if you like.
Thank you. Yeah, great.
I can still remember almost having a little panic attack one of my first days as an intern. I remember sitting in the office and there was another intern sitting next to me on the computer. And I think I'd already asked my registrar about 6 questions that morning about what I should be doing. And it was probably just after lunchtime. And I thought, I can't ask them again what I'm meant to do next. And I was just sitting there stewing for about half an hour. And I really can't believe that I felt that way now, but I remember that feeling very strongly. I would say the best way you can get ready for life as an intern is actually spend more time with the interns and registrars as a medical student and not necessarily the consultants. Always you're going to get great stories from consultants about what it was like when they came through and all that sort of thing. But I've always found that it's been easier to learn from people only 1 or 2 years or 1 or 2 steps ahead of me. and spend as much time with them as you can, including after hours if you have to, or weekends. But that'd be the advice I'd give anyway.
Thanks for that. And then the next question is quite similar. How can medical students get the best out of their clinical rotations?
I can do that. Want me to do that one or someone else?
If you're happy to, yeah.
Look, this is almost one of the things I've spoken about with some of our residents and interns coming through our rotations as well. I don't think you have to do a lot of reading. A lot of the time people will be happy to actually give you knowledge if they like your company. And in fact, if you know every answer, they'll eventually stop asking you questions because it isn't fun for them. So don't panic too much about reading. I guess if a consultant tells you they want you to read something and they're going to ask you about it the next day, okay, so you can bond with them, sort of thing. But like the other guys were saying, I think in some ways, the way too much emphasis is placed on that sort of book learning in terms of how you get ready for things. So I don't know what you can do apart from, I guess, rock up with a good attitude, and that should be enough.
That's true, I guess. And the next, yeah, go ahead.
Can I just add one thing to that, because I really agree with Ross. It's so true that when you, it's really tricky, isn't it? Because when you really you feel connected to the student and you feel that you're having it does help a lot, I think, when you're a teacher. I think when you feel that you can find a connection with the student, and sometimes it's because they've done a bit of reading, but everybody wants to feel like you want to feel, I mean, I love learning from students and often do learn from students. And I really like having that exchange, with students and understanding their perspective. I mean, unfortunately, poor students that come into my unit, I'll often quiz them about how you find the medical course, what's going on. I'll do a sort of mini focus group straight away, like, anybody bullying you, what's happening? Trying to get the lowdown, so I'm not so good to probably be in a unit with. But I think the people I've loved working with as students, I mean, so many of the Monash students, pretty much the majority, are just tremendous to work with. Wonderful people. They're available, they're affable, and they're able. They're curious. I love genuine curiosity. I really struggle with fake curiosity. I struggle with fake, the sort of, now, Professor Leech, I was reading the other night and I came across this paragraph, and you can sort of tell it's a plant, and you just think, oh no, like, let's be real here. Like, I'm a human, you're a human. Tell me what, you're really curious about. Don't make up, I was about to say, don't make up shit, but I'll join in with, Neela's been criticised for her bad language tonight, so I'll add into that. But, no, I'm joking. It was Danny, he's a Puritan. He said, did Neela just say shit? So what I was going to say is that people will, pretend to be curious. I find that disingenuous, and I find genuine curiosity, I just love it so much. Like, if a student asks a question and I think, oh my goodness, that is amazing. Like, it not only makes me think of a next research project, so I'm so grateful to the student for that, but I just love what it signifies, curiosity, because curiosity, the stem of that word is to care. Like, cura is like an old Latin word which means to care. I care enough to want to know. And so to me, curiosity, I've always felt, if we could measure that would be the best surrogate for medical school entry that I could come up with, if we knew how to measure curiosity. So genuine curiosity is beautiful. So I strongly support what Ross is saying. I think the other best advice about how to get the most out of your clinical placement is that the patients teach you. The patients are your best teachers. If you listen carefully to them, and they're non-judgmental teachers. You know, they're not judging you, they're not ranking you, they're just teaching you about illness. And sometimes I come across students and they say, I've seen 45 patients, Professor Leech, I've done 95 cannulations and I've done all this. And I say, oh, great. Like, what have you learned, you know? But for me, you can learn more from one patient by going very deep and wide with that one patient and really focusing on that patient. You know, tell me about your surgery that you had 3 or 4 years ago. How did that go? What happened then? So every student runs around trying to find patients with the best signs, you know, the most exciting signs, but every patient tells a story. And there's a really good book called Every Patient Tells a Story, and I always recommend it because I think it's brilliant.
Great, you've answered another one of my questions, which was any book recommendations. So that's anyone
fine.
wants to jump in here with book or movie or Netflix even or podcast.
Angela, I just kind of highlight something that both Ross and Michelle said, and from a practical point of view, that for students, when they're rotated on clinical units, immerse yourself and assume that you're part of the team. We're still seeing a few students who come along and they have this sort of hesitation. They feel like they're getting in the way. They feel that they don't belong. I think you can dispense with that and be such a useful part of the team. I think you'll learn a lot.
Automatically have a better experience on the ward. So the students who turn up every day, who just are there, who ask questions, the clinicians who are supervising you will pay more attention to you then, and they will realize that you're interested, and then they will take you under their wing. If you just sit in the corner and wait for things to happen for you, they won't, and you tend not to have as much of enjoyable experience. And I reckon that's one thing, like as a medical student, I mean, I would always try to immerse myself as much as possible, but it's difficult when you're a medical student and there are people who are, you know, so what you see as being so far ahead of you in the hierarchy of the whole system, that you feel a bit like, oh, I don't feel like I have the right to ask a question, or I don't feel like I have the right to interrupt the senior grey-haired consultant. But really, when you do start asking, the specialist will be very happy to take you under their wing. I expect most of them, particularly because all the rotations that you'll be doing will be in hospitals where we're used to having students, and we know the difference. Like, we see students who just sit in the corner and don't do anything, and we tend to ignore them because they kind of seem to ignore us. But the students who don't, the students who get involved, we actually will get them to do things. We'll actually pull them aside and say, hold on a sec, there's something really cool over here, come and watch. Yeah.
I just wanted to comment on that. I also want to acknowledge that that's really hard. You know, on reflection, I went through the 6-year medical course at Monash. And so my 4th and 5th year were, even though my social life and my share house life were really rich and rewarding, I found the clinical experience very lonely and very isolating, because it was very hard for me to understand the hospital hierarchy, who I could talk to, who I could approach for help. I didn't necessarily feel welcome in a team. And looking back, I don't think it was because it was a fundamental failing on my part, because by the time I got to 6th year, and certainly by the time I became an intern, resident, etc., I think I'm reasonably well adjusted now. But those couple of early years were really difficult. And so I think what I would say is, overall, medicine probably is changing. And I think most units probably have somebody who is willing to bring you in and show you the ropes. So you don't have to necessarily feel that you have to approach the professor. You know, it can be, as Ross said, the interns or the registrars who introduce you to the unit first and sort of vouch for you. It can be a different consultant. And I think it's also important to highlight to somebody, anybody, what it is that you need. As a junior consultant, one of my pivotal moments was we had a really great student. She was fantastic. She came to clinic, she did ward rounds, she seemed to know a lot, and she never came to theatre. And I finally pulled her aside and I said, why don't you ever come to theatre? And she said, I really want to, but I kind of can't. And I said, well, why not? And she said, well, you know, I'm Muslim and I'm quite happy to show my arms for the time that I'm scrubbing before I put a gown on, but I don't really feel comfortable walking around the theatre complex in short sleeve scrubs. But by the time we get there after our ward round or clinic or whatever, the jackets are always gone. So I come and I try and get changed and there's no jackets. And so I leave. And so for us, it was a really easy fix to say, well, clearly you're not the only person with this problem. So let's get some of the jackets and put it behind the nurse's desk at theatre reception for this cohort of inevitably students, interns, residents, registrars who have specific cultural needs for a jacket. But, you know, for her, it was a really brave thing to speak up, and she didn't look or seem comfortable to share that story. So what I would say is if you do have those specific needs, don't feel that you can't tell someone, you know, tell Michelle if you have to. You know, these are things that can get fixed.
Yeah. And then the next question is, how do you suggest students approach someone they would like to have as a mentor? So Ross and Tim, we haven't heard from you for a while.
If you're working with them on the unit, look, I think students are pretty good at working out, almost like you said, Michelle, earlier. I didn't realise there was as much of an issue around who the students felt comfortable approaching and asking questions or asking them to be a mentor, but it seems to be a very big deal for them. I've just heard a few stories recently. I would say that if you just came up to me and said you want to be my mentor, I'd be happy to have a chat with you, but I feel like that would be an inadequate answer because there must be some more sort of nuance to it if it's someone who's, you know, maybe higher ranking and not as available or that sort of thing. So I don't know, Tim or somebody else, did you want to add to that?
I'm probably not as, because I suspect maybe that's directed more in the sort of the hospital hierarchy. Maybe, I'm not sure, but in general practice, I would say, you know, most of us GPs would be fairly approachable, and you would approach them directly. Is how I would do it in general practice, because most GPs would be open and willing to give you their time and talk about their careers and that sort of stuff. But yeah, probably the hospital world's a little bit more nuanced, as Ross was saying. Sorry, someone else might want to say something.
Angela, I think mentors are picked on the basis of their having the attributes, whether that's personal or career, that a mentee seeks. I think most mentors, most people generally feel quite, complimented if someone else asks to have them mentor them. It's just a matter of whether or not people have the time and you know, that the desires or the objectives of that mentorship are aligned with what the mentor can provide. But I think most people would be good, I think, and Michelle's put a couple of notes about this panel being perhaps a bit biased and not representative of our craft groups, but on the other hand, it's probably not difficult to identify these people who are willing to help you.
I just want to say to that I think the mentors come in all shapes and sizes, and they may not necessarily be the most visible, or they may not be an obvious leader. And whenever I go to the GP awards night, I'm really struck by, I noticed this, Tim, Claire Harrison does this GP awards night every year for the GP practices that take our students. And I am just sometimes, I cannot believe the things, and I understand why, but students say, I want to be like this person, you know, I want to be like this person. And I think it's because they get to see GPs interacting with patients on a very human level, and they see the humanity of people. And most medical students, I feel, when I meet medical students, and from year one, you meet them, and they came into this because they really do want to be good humans, and that's what drives them. That's what drove them. And so then they come in and they see this hierarchy, and they see some scary stuff sometimes. And, whenever they see someone who they think, hey, that person is being what I want to be, I think when you see that person is your mentor already. Like, you don't, people often say, I need to sit down and ask, like, how did you, but I think a lot of it is your mentor will be hundreds of people. It will be hundreds of people that will mentor you. They will do it informally. Sometimes I laugh when people come to me and they say, now I'd like to sit down with you and talk, could you be my mentor? And I think, oh, I mean, I'm not being disingenuous, but I think, really? I mean, there's just so many. So for me, mentorship is like a kaleidoscope. It's no one person, but it is nice to have that chat. And I think the thing to do is do it like teaching on the run. It's just at the end of the ward round, or just at the end of the morning session, or the morning list, or the morning consulting, just say, hey, ask a question, make the world your mentor. And because no one person can offer you everything. And when I listen to this panel tonight, I think, gosh, what an amazing, if you merge these people into one human, what a superhuman it would be. But I think it's about taking those pieces of the world, and rather than one, the answer is not in one person. So, but look, sometimes it's helpful to bounce off one person, but it could just be a person a couple of years ahead of you. It could be someone. Whenever medical students come to me and say, oh, could you be my mentor? I think, oh, I don't know, could you be mine? Because I actually think, as I said, the medical students, I'm thinking, how do you play in the orchestra, and how have you set up a hospital in Nepal and taught migrants in Richmond who don't speak English? And excuse me, what? You want me? I was at the pub, like Neela, I wasn't doing any of this when I was a medical student. So, yeah, your mentors will come in all shapes and sizes, I think.
How can the students get involved and learn to love rotations they hate?
Do you have to?
Who haven't we heard from? Shavi?
I agree with Neela. Neela said, do you have to? And I agree. I don't think you have to. I don't think you need to love everything that you do. So some of us do. So some of us will, you do cardiology and you love it, and then you do gastro and you love it, and then you do peds and you love it. But the majority of people will be will be the opposite. And they'll actually say, you do cardiology, I hate it, and do gastro, I hate it, do peds, I hate it. What am I going to do? Because I hate everything. Eventually, you will probably, the good thing about medicine is that there's so many different things you could do. So you will probably, most people will find something that they actually like to do. And it's actually about just keeping your eyes open to that. And even when you think you've found what you love to do, keep your eyes open, because you might find something else that you like more. For example, when I was a third-year medical student, I really enjoyed neurology. And had I done my BMed Sci after my third year, I would have done it in neurology. Neurology as in the brain, not the other stuff. So had I done my BMed Sci after third year, I would have done it in neurology. And then I don't know where I'd be, probably hating my life. But then now, so then I thought, I'll in peds as well, so that I'll wait till fourth year, do my peds rotation. Did my peds rotation, hated it as well. Didn't like peds, wasn't for me. And then did ONG, and ONG I'd never thought of, so I never considered it. I did not want to do it, but I'd never even, it was just not on my radar. And then I did the rotation, and then I delivered my first baby, and I thought, this is crazy. This is amazing. This is like the best thing ever. So then I thought, okay, maybe ONG should be something I think of now. And so I started to look a little bit more into it. And so I did my BMed Sci in it. And then in final year, I was still throwing up between ONG and neuro. So no, neuro as in brain. Yeah. Biology, yeah. And so I was still throwing up between the two. So I did rotations in both just to make sure. I was pretty sure I wanted to do ONG by then, but I just wanted to make sure. So you don't necessarily have to enjoy every rotation you do, but remember what you're there to, what your objective is to be a good doctor. And the best way to be a good doctor is to know as much as you can about other specialties as well as the one that you actually want to do. So it's a bit like when you're in high school and you're learning factorization and you think, why do I need to know factorization? I don't ever need to know factorization. It's just a stupid thing to know. But it adds to your ability to do bigger problems later on down the track. So if you didn't know, so when you're in year 8, factorization is the exam. The whole exam is about factorization. In year 12, factorization is one step in your problem solving. And it's not even worth a mark. But if you get it wrong, you won't get the marks for the question. So like that. So when you're doing your rotations, everything that you learn is something that you might use or you might find handy at a later stage. And even if it isn't something that you find useful or that you would use, the way that you learn it or you will get something out of it that will make you a better doctor. So I don't think you should, even in rotations that you don't like, I don't think you should just slack off and not do anything. I think you should try to learn as much as you can, even if you don't enjoy it.
Angela, I just wanted to also say that if you are doing a rotation that you hated, apart from all those other good advice, one of the things I'd say is talk to some of your colleagues, some of your medical student colleagues who might be doing the same rotation elsewhere. And it may actually be that it's partly the way the rotation is running where you're doing it, because that can make a huge difference. And then the other thing I'd say is that sometimes it would be important to reflect on some of your own stuff in a rotation and why you particularly hated something. So if you can write it down or really reflect on it rather than just going, I hate this, because it actually there might be something there that I'm not saying going and seeing a psychotherapist about it, but certainly I was just reflecting, because one of my things that I hated at medical school was psychiatry, but I actually love psychiatry now, and I really, really like mental health. And I think as a medical student, I hated it because I just wasn't sure about it. It made me nervous. I wasn't a particularly confident person. And so it was more about me than it actually was about the rotation. So I'd say, talk to your friends about where they're doing their rotation, see if their experience is the same, and maybe also reflect on why you hate it so much.
I just want to say it's such an important point, Tim, such an interesting conversation we're having, because a lot of students struggle when they do psychiatry, at Monash and in actually most courses. And when they start the psychiatry rotation, they feel really, disturbed by what they see, understandably. And they often feel a bit almost traumatized by it, which I also understand. And sometimes that is about the fact that they are feeling that that's bringing stuff up for them personally. But I think a lot of it is actually also that the helplessness, like if you're there as an observer. So a lot of the stuff that medical students experience as traumatic or horrible is because they really feel helpless in that circumstance, whereas we as the clinician, when we often feel helpless too, of course, but we often have a particular set of tasks that we are going to do as a result of seeing this awful thing. But, I think, Shavi, an example could be, postpartum hemorrhage, where the woman, it turns into an acute scenario and the woman is dying, or a very distressed psychiatric patient who requires sedation, or we've each got our areas where awful things will be seen by students and the rotation will be awful for them. But a lot of it is the relative ability of the student to contribute to care. And I think it comes over as stress and, unpleasant for them. And I think that is something that we need. It's hard to work out how to handle that sometimes, but I do believe that that's one of the reasons why maybe you didn't like psychiatry. Maybe there's lots of reasons, but I know that you would be not alone, Tim, because many students, when they start the psychiatry rotation, say, I feel really upset. I feel this is horrible to watch this, Yeah.
Yeah, it's certainly a very hard task to go from all the usual things that you're doing in third year to then being thrown into the that fourth year acute psychiatry. Very much so different.
Have you experienced any bullying or discrimination during your career?
Yeah, I'll put my hand up. Absolutely, 100%. Surgical training there's documented evidence of how prevalent it is. But I think one of the things that we don't talk about in medicine is that every specialty has issues with that. Every specialty has bullies, and in many ways, what I now see is the College of Surgeons, to their credit, in the last 4 to 5 years, have really taken significant strides to change those behaviours, or at least make people aware that those behaviours are unacceptable, whereas not all the colleges and specialties have taken such a proactive approach to that. In my experience, it doesn't take a lot of bullies to make your life miserable. I look back now upon the terms which I found quite hellish, but really it was only 1 or 2 individuals within an institution that can make your life very, very, very difficult. And particularly in surgery in Victoria, where a lot of VMOs would work at more than one network. And if you're on a training program where your training takes you from network to network, then it can move you. Those bullies can infect your experience at more than one institution, and they can carry their prejudices with them, and they can make people that you work with prejudiced before you arrive. So it's a massive problem in surgery, and I know that all sounds terribly depressing and demoralizing, and like you should all leave medicine instantly, which is not how I want it to sound. I think that I look at people who are 15 years senior to me and they had it worse than I did, and I look at people who are 5 years below me and their experiences are improving because there are more reporting frameworks, there are more response frameworks, and I do think genuinely that medicine is changing. And one of the big things that's changing is that I don't think there are very many places where you can't find an ally who will take up your cause and give you support. And even if they can't necessarily change the behaviour of the bully, even if as a professional we haven't managed to get them out, there'll be enough people that will give you a bit of a cocoon and protect you from those behaviours. And I think that, if anyone ever has any issue, I think anyone on this panel would be someone that you could reach out to. And there are, I can't count 6 people on this panel. There's 100 people out there for every one of us. There's enough doctors who will take up your cause. So yes, it's there. Yes, it's horrendous. Yes, it's toxic. No, you don't have to put up with it on your own.
The other thing, Neela, that's really everything you said again, exactly right. The other thing that I think is really important is that when you are bullied or when you see other people being bullied, that you recognize it and you notice it, and that you decide what sort of doctor you want to be, so that when you finish, that you don't propagate that behavior. What tends to happen is that medical students, you guys are all very innocent and very happy, and everything's great with life, except that you're poor and, you eat 2-minute noodles for dinner and, the usual sorts of things. But everything else is really good and happy. But then something happens along the way during your training. So all the really angry surgeons at some point were medical students, just like you. But something has happened along the way that has changed them. So the system does that. The network, the hierarchy, everything, the way that it's run does that. So what you can do to actively avoid that is to be aware of how the system is trying to change you and not let it happen. So not let yourself be sucked into that culture of bullying, and then lead by example, so that the people that you train also, or the people that you teach when you get more senior, also want to do the same thing. And then when you do that, as we do that, we will slowly, it won't happen, hopefully it happens in our generation, but it won't happen quickly. We will slowly stamp it out. But it's not going to be something that can happen quickly. And it's great that the College of Surgeons is making moves and other colleges are making moves, but that's not going to solve the problem in one smack. It's going to take time, and it's going to take everybody recognizing that and changing their own behavior, and that will have a lead-on effect.
And this is going to be the final question for the night. Did you ever find it difficult to maintain a balance between getting through the patients and getting through your ward round? Engaging with your patients and getting through the ward round.
Actually, I can maybe at least answer from the perspective of general medicine. Most of us have a lot of substantial appointments at public hospitals. So the short answer to your question is it doesn't matter what time the ward round finishes. We do what we need to. And we're not distracted by the need to go to theatre, etc. And that's our great advantage over some of the other crafts.
So can I say one more thing before we finish about bullying, which is that because I feel a responsibility about this as well, that you can anonymously report bullying as well, and please do. It has been helpful to us to sort of circle in on some folks and speak to health services and things like that. So please do. I agree though that there's plenty of scary physicians, and most of the surgeons I work with are really lovely, and I've never felt bullied by surgeons, but I've had some scary physicians. I think one of the most important things is not to be taking it personally. It's hard because everything feels personal, but nothing really is. Most people's behavior is about them, not about you. And it's really hard to do. But if you stop for a minute and think that, anger and distress is actually just corroding the vessel that it's in, that person is a suffering human in some way. And not that it's up to you, young medical students, to find compassion for these people, but everyone, the way out of this is some kind of compassion for everyone involved and also for yourself. So if you are in a struggle situation, please reach out anonymously or to somebody you trust. We really don't want to have this kind of culture in the Monash alumni or graduates or course or educators. So just want to make that point.
So I think that's all the questions for today. I'd like to thank all of you for joining as speakers, Prof. Leech, Neela, Danny, Shavi, Ross, and Tim, and thank you for your valuable time, especially during this crisis, and to everyone online attending. It's been an interesting evening, and we've heard a lot of interesting stories. I'll hand over to Sam just to finish this event.
Thanks, Angela. I don't really have anything more to add. Just thank you so much to all of you for agreeing to come and to speak. It's too bad that you can't kind of see what the students have been saying in the Facebook Live, but we've had some lovely feedback, and everyone's really enjoyed tonight. So we really appreciate it. We also want to say thank you to MIPS for sponsoring us. They've always looked after us, and we really appreciate their support as well. Yeah, and sorry to everyone in the live stream that we didn't get through every single question. And thank you for participating, for sending your questions in. Yeah, hopefully we'll have another exciting event soon. Thank you, everybody.
Thanks all.
Thank you.
Take care.
Take care. See you. Nice to see you all. See you.
Bye. Thank you.
Bye.